General surgery and thoracic trauma. Q&A essential questions and answers in thoracic trauma management. Welcome to the Everything Surgery podcast. Today we ask 100 essential questions on the management of thoracic trauma based on the ATLS guidelines. Pause the video when you hear the word answer to attempt answering the question. Let's begin. Question: what is the first priority in any trauma patient? Answer: the first priority is the primary survey, which follows the sequence of airway with cervical spine protection, breathing, circulation, disability, and exposure or environment. Question: what are the immediate life-threatening thoracic injuries, sometimes called the deadly dozen? Answer: the immediate life-threatening thoracic injuries include airway obstruction, tension pneumothorax, open pneumothorax, massive hemothorax, flail chest, and cardiac tamponade. Other critical injuries often discussed in trauma literature, though not all strictly thoracic, include aortic injury. Question: what is the single most important physical exam finding in thoracic trauma? Answer: the most important finding is auscultation of the chest for breath sounds. Question: what is the most sensitive initial diagnostic test for thoracic trauma? Answer: the most sensitive initial diagnostic test is a chest X-ray performed in the trauma bay, typically in the anteroposterior supine position. Question: when is an extended focused assessment with sonography for trauma, or E-FAST exam, used? Answer: the E-FAST exam is used rapidly at the bedside during the primary survey to identify pericardial fluid, hemothorax, or pneumothorax. Question: what is the definitive management for a compromised airway? Answer: the definitive management is endotracheal intubation. Question: what is a key consideration during intubation in a trauma patient? Answer: one must always assume a cervical spine injury until proven otherwise and maintain inline stabilization during intubation. Question: what are signs of a potential airway injury? Answer: signs include hoarseness, stridor, subcutaneous emphysema, and an expanding neck hematoma. Question: what is the pathophysiology of a tension pneumothorax? Answer: a tension pneumothorax occurs when a one-way valve leak allows air to enter the pleural space but not exit, leading to mediastinal shift and impaired venous return. Question: what are the classic signs of a tension pneumothorax? Answer: classic signs include respiratory distress, rapid heartbeat, low blood pressure, deviated trachea, absent breath sounds, hyperresonance on one side, and jugular venous distension. Question: what is the immediate treatment for a tension pneumothorax? Answer: immediate treatment is needle decompression at the second intercostal space in the midclavicular line on the affected side. This is a clinical diagnosis, so one should not wait for imaging. Question: what is the definitive management after needle decompression? Answer: the definitive management is tube thoracostomy, also known as chest tube placement. Question: what defines an open pneumothorax, or sucking chest wound? Answer: an open pneumothorax is defined by a chest wall defect larger than 2/3 the diameter of the trachea, allowing air to be sucked into the pleural space with each breath. Question: what is the initial field and emergency department management for an open pneumothorax? Answer: the initial management is to seal the wound with a 3-sided occlusive dressing, which prevents air trapping but allows air to escape if a tension pneumothorax develops. Question: what is the definitive management for an open pneumothorax? Answer: definitive management includes tube thoracostomy, with placement remote from the wound, and surgical closure of the defect. Question: how is a massive hemothorax defined? Answer: a massive hemothorax is defined as 1,500 milliliters of blood on initial chest tube output, or more than 200 milliliters per hour for 2 to 4 hours. Question: what are the clinical signs of a massive hemothorax? Answer: clinical signs include shock, which is evidenced by low blood pressure and rapid heartbeat, absent breath sounds, and dullness to percussion on the affected side. Question: what is the primary treatment for a massive hemothorax? Answer: the primary treatment is tube thoracostomy to evacuate blood and allow lung re-expansion, which also provides tamponade. Volume resuscitation with blood products is essential. Question: what is the most common source of bleeding in massive hemothorax? Answer: the most common sources are the intercostal or internal mammary arteries. Bleeding from lung tissue often stops spontaneously. Question: what is the indication for emergent thoracotomy for hemothorax? Answer. Emergent thoracotomy is indicated if the initial chest tube output exceeds 1,500 milliliters, or if there is ongoing output greater than 200 milliliters per hour for 2 to 4 hours. Question. What is the definition of a flail chest? Answer. A flail chest is defined as fractures of 3 or more consecutive ribs in 2 or more places, resulting in a segment that moves paradoxically, inward on inspiration and outward on expiration. Question. What is the primary life-threatening problem with a flail chest? Answer. The major threat is the underlying pulmonary contusion, not the instability of the chest wall. Question. What is the mainstay of management for a flail chest? Answer. Mainstay treatment includes adequate analgesia, such as epidural anesthesia, and pulmonary hygiene. Mechanical ventilation is reserved for respiratory failure and not used solely for chest wall stabilization. Question. What is Beck's triad? Answer. Beck's triad consists of low blood pressure, jugular venous distension, and muffled heart sounds. This classic triad is associated with cardiac tamponade, though not always all present. Question. What is pulsus paradoxus? Answer. Pulsus paradoxus is a decrease in systolic blood pressure of more than 10 millimeters of mercury during inspiration. Question. What is the most reliable diagnostic tool for cardiac tamponade? Answer. The most reliable diagnostic tool is bedside extended focused assessment with sonography for trauma, showing pericardial fluid. Question. What is the definitive treatment for cardiac tamponade? Answer. Definitive treatment is pericardiocentesis as a bridge, or emergent thoracotomy with a pericardial window. Question. How does a pulmonary contusion present? Answer. Pulmonary contusion presents with low oxygen levels and fluffy infiltrates on chest X-ray that worsen over 24 to 48 hours. Question. What is the management for pulmonary contusion? Answer. Management is supportive, including supplemental oxygen, careful fluid resuscitation, pain control, and avoidance of mechanical ventilation if possible. Question. What is the most common site of traumatic aortic rupture? Answer. The ligamentum arteriosum, just distal to the left subclavian artery, is the most common site. Question. What is the classic chest X-ray finding in traumatic aortic injury? Answer. The classic finding is a widened mediastinum. Other signs include a blurred aortic knob, apical cap, deviation of the nasogastric tube, and depression of the left mainstem bronchus. Question. What is the gold standard for the diagnosis of traumatic aortic injury? Answer. The gold standard is computed tomography angiography of the chest. Question. What is the initial management goal for a stable patient with traumatic aortic injury? Answer. The goal is strict blood pressure control, with systolic pressure less than 100 to 120 millimeters of mercury, often using beta blockers to reduce shear stress. Question. What are the definitive repair options for traumatic aortic injury? Answer. Thoracic endovascular aortic repair is now first line for most patients, while open repair is less common. Question. What are clues to a tracheobronchial injury? Answer. Clues include a massive air leak from a chest tube, persistent pneumothorax, subcutaneous emphysema, and the fallen lung sign on chest X-ray. Question. What is the definitive management for tracheobronchial injury? Answer. Definitive management involves bronchoscopy for diagnosis and surgical repair. Question. What is the most common clinical manifestation of blunt cardiac injury? Answer. The most common manifestation is abnormal electrocardiogram findings, including arrhythmias, segment changes, and heart block. Question. What is the screening protocol for blunt cardiac injury? Answer. All patients should have an electrocardiogram. If normal, no further monitoring is needed. If abnormal, monitor with continuous telemetry for 24 to 48 hours. Question. When is an echocardiogram indicated in blunt cardiac injury? Answer. An echocardiogram is indicated for patients who are hemodynamically unstable or who develop new arrhythmias, to rule out structural injury. Question. Which side is more commonly injured in diaphragmatic trauma? Answer. The left side is involved about 70% of the time, as the liver protects the right side. Question. What is the best initial test for diaphragmatic injury? Answer. The best initial test is a chest X-ray, which may show the nasogastric tube or abdominal contents in the chest. However, this is often missed initially. Question. What is the most sensitive test for diaphragmatic injury? Answer. Computed tomography scan is the most sensitive, especially looking for the collar sign or dependent viscera sign. Question. What is the definitive management for diaphragmatic injury? Answer. Surgical repair is required, often via laparotomy due to the risk of herniation and strangulation. Question: why is esophageal injury so dangerous? Answer: esophageal injury can lead to mediastinitis, which is associated with a high risk of death. Question: what is a classic finding of esophageal injury? Answer: a classic finding is pneumomediastinum on chest X-ray. Question: how is esophageal injury diagnosed? Answer: diagnosis involves a water-soluble contrast esophagogram, followed by thin barium study if suspicion remains high and the initial study is negative. Computed tomography may show extraluminal air or fluid. Question: what is the treatment for esophageal injury? Answer: treatment includes broad-spectrum antibiotics and emergent surgical repair. Question: where is the correct placement for needle decompression in tension pneumothorax? Answer: needle decompression should be performed at the second intercostal space in the midclavicular line on the affected side. Question: what is the biggest complication of needle decompression? Answer: the most common complication is failure due to the needle not reaching the pleural space in large patients. Question: what is the safe triangle for chest tube insertion? Answer: the safe triangle is bordered anteriorly by the lateral border of pectoralis major, posteriorly by the lateral border of latissimus dorsi, inferiorly by the nipple line at the fifth intercostal space, and apex at the axilla. Question: what is the correct intercostal space to enter the pleura for a chest tube? Answer: the pleura should be entered over the top of the rib in the fourth or fifth intercostal space to avoid the intercostal neurovascular bundle. Question: what size chest tube is typically used for hemothorax? Answer: large bore tubes, usually 36 to 40 French, are used for hemothorax. Question: what size is typically used for a simple pneumothorax? Answer: a smaller tube, such as 28 to 32 French, may be used for simple pneumothorax, though larger tubes are often chosen in trauma. Question: how should a chest tube be managed after insertion? Answer: it should be connected to a pleural drainage system with 20 centimeters of suction. Question: when is a chest tube ready to be removed? Answer: removal is appropriate when there is no air leak, drainage is less than 200 milliliters in 24 hours, and the lung is expanded on chest X-ray. Question: what is the primary goal of an emergency department thoracotomy? Answer: the goal is to relieve cardiac tamponade and control hemorrhage from the heart or great vessels. Question: what are the indications for emergency thoracotomy in penetrating trauma? Answer: indications include witnessed loss of vital signs in the emergency department or just prior to arrival, within 10 minutes. Question: what are the indications for emergency thoracotomy in blunt trauma? Answer: there are very poor outcomes. It is rarely indicated, only when vital signs are lost in the emergency department. Question: what is the first structure divided during a clamshell thoracotomy? Answer: the sternum is divided, typically with special shears or a saw. Question: what is the first maneuver after opening the pericardium for tamponade? Answer: one must control cardiac wounds, for example using a finger, a balloon catheter, or surgical staples, then perform internal cardiac massage. Question: what is the most common complication of a chest tube? Answer: the most common complication is malposition or inadequate function. Question: what is a retained hemothorax? Answer: a retained hemothorax is blood that remains in the pleural space after chest tube placement. Question: how is a retained hemothorax managed? Answer: early video-assisted thoracoscopic surgery is preferred over a second chest tube for evacuation. Question: what output complication indicates the need for surgery? Answer: persistent chest tube bleeding exceeding 200 milliliters per hour for 2 to 4 hours is an indication for surgery. Question: what is post-expansion pulmonary edema? Answer: it is edema that occurs after rapid evacuation of a large or long-standing pneumothorax or hemothorax, managed supportively. Question: what is the most common rib fractured in trauma? Answer: the seventh rib is most frequently fractured. Question: what is the significance of a first or second rib fracture? Answer: these fractures indicate high-energy trauma and are associated with injuries to the great vessels, brachial plexus, and tracheobronchial tree. Question: what is a simple pneumothorax seen on computed tomography but not on chest X-ray called? Answer: this is called an occult pneumothorax. Management remains controversial. Question: what is the deep sulcus sign on a supine chest X-ray? Answer: it is a very lucent costophrenic angle, indicating a pneumothorax in a supine patient. Question: What is subcutaneous emphysema a sign of? Answer. It is a sign of air tracking from an injury to the airway, lung, or esophagus. Question. What is the mortality rate from traumatic aortic rupture? Answer. Approximately 80 to 90% die at the scene. Of those reaching the hospital, timely diagnosis and repair are critical. Question. What is the most common cause of death after thoracic trauma? Answer. The most common cause is head injury, followed by hemorrhagic shock. Question. What is traumatic asphyxia? Answer. It is caused by sudden, severe compression of the chest, resulting in facial plethora, small red spots, and subconjunctival hemorrhage. Question. What is the role of magnetic resonance imaging in thoracic trauma? Answer. The role is minimal in the acute setting. It is more useful for evaluating suspected spinal cord injury. Question. What is chylothorax? Answer. Chylothorax is the presence of milky pleural fluid with high triglycerides due to thoracic duct injury. Question. What is the initial fluid of choice for resuscitation in trauma? Answer. Blood products in a 1:1:1 ratio of packed red blood cells, plasma, and platelets are preferred for hemorrhagic shock. Question. What is the lethal triad of trauma? Answer. The lethal triad consists of acidosis, hypothermia, and coagulopathy. Resuscitation strategies aim to correct these simultaneously. Question. What is damage control surgery? Answer. It is abbreviated surgery to control bleeding and contamination, followed by intensive care unit resuscitation and planned reoperation. Question. When is a thoracotomy incision used? Answer. It is used for access to the posterior mediastinum, descending aorta, and most of the lung. The posterolateral approach is classic. Question. When is a median sternotomy incision used? Answer. This approach allows access to the heart, great vessels, and anterior mediastinum. Question. What is the most common injury found during emergency department thoracotomy? Answer. A cardiac wound, often of the right ventricle, is most common. Question. What is the survival rate for emergency department thoracotomy after penetrating cardiac injury? Answer. Survival is approximately 15 to 35% for stab wounds, and 5 to 15% for gunshot wounds. Question. What is the role of bronchoscopy in massive hemoptysis? Answer. Bronchoscopy is used to identify the source of bleeding and potentially isolate the lung, for example with balloon tamponade. Question. What is a pulmonary hail injury? Answer. This term refers to a combination of pulmonary contusion, laceration, and hematoma. Question. What is the seatbelt sign on the chest? Answer. It is a contusion across the chest from a seatbelt, associated with blunt cardiac injury and sternal fractures. Question. With which injuries is a sternal fracture associated? Answer. Sternal fractures are associated with blunt cardiac injury and thoracic spinal fractures. Question. What is the management for most rib fractures? Answer. Management includes multimodal analgesia and pulmonary hygiene, such as incentive spirometry. Question. What is the significance of a scapular fracture? Answer. Scapular fractures result from high-energy mechanisms and are associated with ipsilateral thoracic, vascular, and brachial plexus injuries. Question. What is an extrapleural hematoma? Answer. It refers to a collection of blood between the parietal pleura and chest wall, often from intercostal vessel injury. Question. What is the computed tomography angiogram sign for aortic injury? Answer. The sign is a pseudoaneurysm or intimal flap visible within the aortic lumen. Question. What is the most common fatal blunt thoracic injury? Answer. Traumatic aortic rupture is the most fatal. Question. What is the primary mechanism of injury in blunt cardiac injury? Answer. The primary mechanism is deceleration and direct compression between the sternum and the spine. Question. What is the most common arrhythmia after blunt cardiac injury? Answer. Sinus tachycardia is the most common, though atrial fibrillation and ventricular tachycardia can also occur. Question. What is the management for a patient with stable vital signs and a widened mediastinum on chest X-ray? Answer. Computed tomography angiography is required to rule out aortic injury. Question. What is the vanishing lung sign on chest X-ray after chest tube placement? Answer. The lung fails to re-expand, suggesting a major airway injury or trapped lung. Question. What is the initial step if a chest tube is not draining? Answer. The tube should be milked or stripped to clear clots, checked for kinks, and the system ensured to be on suction. Question. When is a thoracotomy indicated for a persistent air leak? Answer. Thoracotomy is indicated after several days, usually 5 to 7. if the leak is high flow and the lung fails to re-expand, or earlier for a proven bronchial injury. Question: what is the most common organism causing empyema after hemothorax? Answer: the most common organism is Staphylococcus aureus. Question: what is the definition of massive subcutaneous emphysema? Answer: it is defined as air tracking into the neck, face, and abdominal wall, which may indicate a major airway injury. Question: what is the ultimate principle of advanced trauma life support in thoracic trauma? Answer: the ultimate principle is to treat first what kills first, quickly identifying and managing immediately life-threatening conditions during the primary survey. That's it. Thanks for tuning into today's episode. If you have any questions, leave it in the comment section. If there are any topics you are interested in seeing on this channel, state it in the comment section. If you enjoy the video, remember to like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.